I'm Dan Lubin, if you guys. Okay, hello. So I'm Dan Lubin. If you guys haven't met me, I'm an assistant professor of pathology here. I started a year and a half ago now, and I sign out head and neck pathology as well as cytopathology. And salivary gland is one of the things that got me interested in head and neck pathology originally. It's an area where there's quite a lot of morphologic diversity in lesions. And they're also quite rare. So it's not something that we tend to see, every day. So as a resident, I found these very challenging because I didn't really encounter a lot of them during my rotations. But they were also so much more exotic because of that. And anyways, I think they're quite beautiful and interesting lesions, and I hope you guys all agree by the end of this. And I'm just going to be covering the basics of salivary gland pathology. So there's just so much nuance, and all of these tumors can have different variants and different types of metaplasia that make them look quite unusual, not characteristic. But I'm going to try to stick to the basics today because this is a resident lecture after all. Anyway, so feel free to interrupt me. I really appreciate it when you guys interrupt me, and we can just make this more of a conversation than an actual lecture. That would be nice because I have 2 hours of this, so it will help me get through it. All right, so let's start. So we're going to talk about the salivary gland today, as I said. So we're going to be starting with the anatomy and the histology of the salivary gland, just so we can get a basic overview of how the salivary glands are structured. Then we'll take a minute to talk about non-neoplastic lesions. I'm going to talk about just a handful of things that we might see. Then I'm going to give you a little intro into neoplasms in general and basic concepts in salivary gland neoplasia. Then we're going to spend a minute talking about the bread and butter, the stuff we see almost every day, PAs and Warthin tumor. And then I'm going to talk about the more complicated entities and a way that we can sort of differentiate them and approach them with a good differential diagnosis. All right, so let's start. So prologue. So let's talk about the anatomy here. So there are 3 major salivary glands, and they are paired. Actually, this past year, there was a 4th major salivary gland, which was described in the nasopharynx by some radiation oncologists, which is sort of interesting. But, to be decided whether that's accepted broadly. But we generally recognize 3 major salivary glands, and they're the parotid gland here, which is right in front of your ear. Then you have the submandibular gland, and then more medially, you have the sublingual gland. And the parotid gland will drain through the Stenson duct, which empties right here along the buccal mucosa. And the submandibular gland will drain through the Wharton's duct, which empties right here under the tongue, which can lead to some issues, which I'll discuss a little bit later. But then there are also minor salivary glands that are distributed everywhere. So anywhere in the aerodigestive tract, from the sinonasal mucosa down through the trachea. So because of that, we can see salivary gland tumors pretty much anywhere in both the head and neck, as well as the respiratory system, and even in the esophagus. So here we have a little sinonasal mucosa here where we see some salivary glands. This is the epiglottis. And if you remember from my larynx lecture last year, it is fenestrated. So these are the fenestrations in the epiglottis. And in this case, we see a bunch of salivary gland tissue here in the fenestrations. Here we have the larynx, we have the true vocal cord here, and the false cord up top. And the false cord is absolutely lined with these salivary glands here. So all these little grape-like clusters here are salivary glands. And then, like I said, esophagus also has some salivary gland tissue. So sort of distributed throughout, and that's what makes these sort of fun. So, your colleagues from other subspecialties might be showing you lesions because they're worried about salivary gland carcinoma. All right, so this is the parotid gland, the structure of the parotid gland. And I show this because it's probably where we see most of our salivary gland neoplasms. And it's important to know the anatomy a little bit. So the parotid gland is divided into superficial lobe and the deep lobe by the facial nerve, which runs right through it. And this is sort of an artificial division that we've created. It's not like there's actually a fascial plane here, but it's a division which makes sense from a clinical perspective because surgeons, when they're resecting these tumors, obviously want to spare the facial nerve. It's a very important nerve. And then there are also these very important vessels, which are located here in the deep lobe. So if possible, we want to help our surgeons do minimal resections and preserve the facial nerve and not get into these dicey areas with these vessels. So it's an important distinction from a clinical perspective. The other thing that you should take away from this image here is that there are lymph nodes here in the parotid gland, so don't forget about that. And we'll talk about that in a minute as well. So the structure of salivary glands in general is similar to a lot of exocrine organs, so like pancreas, like breast. And it consists of this terminal acinus here, which is sort of like this cul-de-sac of cells, which creates various enzymes. And then they eventually dump into these progressively larger ducts here. So it's sort of structured kind of like grapes on a stem. And in fact, if you look at the etymology of the term acinus, is originally used in the medical sense by this Italian anatomist, Marcello Malpighi. And the term acinus actually comes from the Latin for berry or grape. So it sort of makes sense. So he was appreciating that as well, this sort of grape-like structure when he came up with that term. All right, so this is a cartoon depiction of the various salivary gland elements. So here we have that terminal cul-de-sac of acinar cells here. And then those will eventually dump into these intercalated ducts, which are located just adjacent to these acini. And then those eventually secrete into these larger striated ducts, which are more columnar and have more eosinophilic cytoplasm. And then those eventually secrete into these excretory ducts, which are located between the salivary gland lobules. And I'll show you all that. And then the other thing to know is that there are both basal and myoepithelial cells that are surrounding these structures. And myoepithelial cells are quite interesting. So they share some properties of epithelial cells, and they will stain with cytokeratins, but they also have some contractile properties, and they will line the ends of these units and squeeze. I tell people it's sort of like squeezing from the bottom of the toothpaste. You want to squeeze from the bottom, so that's why myoepithelial cells are located here. So this is what it looks like in actual histology. So here, this is parotid gland. So here, all these purple cells with these granules here, these are the zymogen-rich acinar cells, and they're in these little clusters. And these very tiny duct structures here are intercalated ducts, and sometimes they're sort of hard to appreciate, but as you start looking around, you'll notice them more and more. And then these cells, like I said, they're a little more eosinophilic and columnar are the striated ducts, and then eventually these excretory ducts, which are located between the lobules rather than within them. Other thing to notice, we have a little fat here, so don't forget you can get lipomas in the salivary gland. We have some nerves, so you can get schwannomas. So don't forget about your mesenchymal lesions as well.
Hey, Dr. Lubin.
Yeah.
So are the intercalated ducts the guys that are closest to the acini, and then those lead into the striated ducts and then the exocrine ducts?
Yes,
right?
That's right. So these here, these little, so the intercalated ducts are sort of difficult to appreciate, but yes, they're the ones that are right next to it. And actually some of these cells here, these little cleared out cells, these are probably intercalated duct cells as well. So once you start looking for them, you'll appreciate them. Here's another intercalated duct right here. They're just very tiny, so they're hard to appreciate.
Awesome.
Yeah. Okay, and then so if you look at the histology of the major salivary glands, this is something that we like to pimp the residents on. So this is a good slide to pay attention to for when you roll around on the head and neck pathology here, because we'll probably ask you about it. It's a dumb, easy pimping question, but parotid gland is almost all serous type cells, which means they're these cells with these zymogen granules, which we use to digest our food. So all these purple zymogen granules here. By the way, these are intercalated ducts. There's another intercalated duct there, and here's a striated duct, just so you can appreciate again in another picture, intercalated duct here. So yeah, parotid is all serous cells, whereas submandibular gland, you'll start to get a little bit of mucinous cells. So here are the mucinous cells. These are also acinar cells. They just are pure mucin, whereas these are, again, the zymogen-rich serous type cells. And then within the sublingual gland, it's almost all mucinous cells. So as you go from lateral to medial, you get more mucin. All right, so let's talk about some non-neoplastic lesions. So probably the most common thing we see, definitely the most common thing the surgeons see, and we often don't get these specimens, is silolithiasis. So incredibly common. And it's interesting, actually, the majority of cases of silolithiasis involve the submandibular gland. So remember, I showed you that the Wharton duct of the submandibular gland empties right under the tongue. So here's a little silolith here. And it's probably because, well, first of all, it is located right under the tongue. So you could imagine this is an area where you can get a lot of these concretions and proteins building up. Also, the submandibular gland, the Wharton duct, empties the submandibular gland the duct ends up going superiorly. So it sort of moves in a superior direction. So gravity might pull all that crap down into it. And also, for whatever reason, the secretions of the submandibular gland are a little more alkaline than those of the parotid gland. So for all those reasons, it's really prone to silolithiasis. Here's a histologic picture. I'll show you another one of just a big duct that's like full of this dense calcified material. And you should be able to appreciate this on imaging relatively easily. So here's another picture. We have this dilated duct. In this case, the big stone has been removed, and then the surrounding parenchyma will show inflammation and some atrophy. And so here's what you see in general in chronic inflammation of any major salivary gland. You see the ducts are still remaining here. See these little ducts? But we don't see any acini. So this is just complete atrophy of the acinar tissue here, which is what we generally see in chronic inflammation. And eventually these ducts will go away too, and you'll just see fat. And sometimes we'll get specimens from patients who've had chronic inflammation for a long time, and it's labeled as parotid gland, and all you see is fat, and you're like, wow, surgeon, you need to go back to school. And really, they don't. It is the parotid gland, it's just there's nothing remaining. Okay, so this is another interesting condition, relatively rare, but we get a handful of cases a year. So nodular oncocytic hyperplasia. So oncocytosis of salivary glands occurs as we age in all people. So if you look at the salivary gland, you'll see that just the normal acinar cells are undergoing oncocytic metaplasia. But for whatever reason, there are some patients that tend to get these nodular proliferations of oncocytes. So they tend to be elderly patients, so usually in their 60s or 70s at the very least. And often it'll be bilateral, parotid most frequently, and it's unclear why that's the case. And histologically, you'll just see a bunch of these nodules of oncocytes. And then you can appreciate some oncocytic metaplasia of the acinar cells in the background too. So in this case, this was an example where we see a big nodule of oncocytes here, some oncocytes here, here's another nodule here, here, here. And then you can also see sometimes some cystic change with the oncocytic lining, which you're seeing in this case here. So here's a big cyst, there's some oncocytes. In any event, it's considered to be a non-neoplastic condition, and it's generally asymptomatic, and usually these things are just discovered incidentally. But assuming you can make the diagnosis beforehand, these patients don't really need any management, just a benign weirdo condition. All right, this is an unusual entity. So IgG4 related disease in the salivary glands. I think you guys have probably heard about IgG4 in other tissues, and it actually can occur in salivary glands, not infrequently. So this will be in older patients, similar to all IgG4 related disease, and there's an equal gender distribution. So this will clinically be manifested by swelling and often with pain with eating, which is a somewhat unusual symptom. And for whatever reason, submandibular gland is most frequently affected, and this will be usually a unilateral process. You can have other organ involvement. So anywhere from 60 to 70% of patients will have other organs involved at the time of diagnosis. In the head and neck, the most frequent organ that we see is the lacrimal glands. So you'll see some eye symptoms. And the histology is sort of similar to what we see elsewhere with IgG4. So you'll see fibrosis throughout and a dense lymphoplasmacytic infiltrate, and there will be acinar atrophy. The one thing that's sort of interesting is that the fibrosis tends to accentuate the intralobular septae. So you'll get this preserved lobular architecture, which I'll show you in the next images coming up here. And then every different organ has a different number of IgG4 cells you need per high power field. In the case of salivary gland, it's over 100 IgG4 positive cells per high power field. So this is what IgG4 related disease looks like. So here we have a gland that's completely replaced with this fibrosis and inflammation. And like I was saying before, you have these, what used to be lobules of salivary gland, and the interlobular septae are really prominent here. So the fibrosis is really featured prominently between these, what were the lobules. So you still get this preserved lobular architecture, which is somewhat interesting. And then on high power, you see the similar findings you see elsewhere. You can get a hint of storiform fibrosis like you do in other organs, though for some reason it's not as prominent in the salivary gland. And then of course, just a dense lymphoplasmacytic infiltrate. And then you just got to order your IgG4. All right, so we'll get into salivary gland neoplasms. We'll talk about a little background stuff. So one thing to be aware of as we approach nodules is even before you get the lesion, you can get a sense of the risk of malignancy. Obviously, you got to incorporate the imaging findings, but just knowing where the lesion is coming from can give you a sense for the risk of malignancy. So for neoplastic lesions, as we move from the parotid gland medially, you get increased risk of malignancy. So for parotid gland, only about 20 to 25% of these lesions are going to be malignant. Submandibular, it gets up to about half of them. And then in the sublingual, the majority of these lesions will be malignant. So just knowing where the lesion is coming from gives you a better idea about what to expect. And like I said before, the parotid gland is full of lymph nodes. So you guys have probably seen this image before from my cytology lectures, but it's good to remind you. We get lymph nodes in the parotid gland, and actually you can have quite a bunch. So this is from an autopsy study where the folks just submitted entire parotid glands on the decedents and just counted the number of lymph nodes. And they found in some folks, over 15, over 20 lymph nodes just in the superficial parotid alone. So this is superficial parotid here. This is the deep lobe, remember, deep to the facial nerve. So the superficial lobe of the parotid in particular tends to be full of lymph nodes. So remember, you'll always have to keep Mets on the differential as well as lymphoma. And I will talk about both of those in a minute. So Mets of the parotid, these are actually quite common because salivary gland primaries are already quite rare and malignancies of other organs are far more common. We do see quite a lot of metastases to salivary gland. And in fact, they make up about a third of parotid malignancies. So you get a high grade malignancy in the salivary gland, 1 out of every 3 times you'll find that it actually is a metastasis. And the most common things to metastasize are cutaneous malignancies. So the parotid lymph nodes drain a lot of the cutaneous tissues of, like your scalp and your face. So we'll get a lot of squamous cell carcinoma. That makes up about half of the cases. Melanoma is about another quarter. Then you'll get actually a surprising amount of Merkel cell carcinomas in the parotid gland as well. And then, just every other organ can metastasize here. So if a patient has a history of malignancy already, just remember to rule that out. So especially if it doesn't fit any of the WHO definitions of primary salivary gland malignancies, just try to rule out metastasis. And then I'm just going to take a minute to talk about salivary gland lymphoma. So you can get any type of lymphoma in the salivary gland, and your hematopathology attendings will do a better job of teaching you about lymphoma. But I just wanted to take a minute to talk about the nuances in salivary gland. So in the salivary gland, it actually is relatively common. So similar to metastasis, you always have to consider lymphoma on your differential. So about 10 to 30% of salivary gland malignancies actually will be lymphoma. Tends to occur in older patients, so 80% of cases are in patients over 50 years of age. So, older. And then one thing to be aware of is that Sjogren's syndrome really confers a risk of lymphoma. So patients with Sjogren's syndrome have a 40 times increased risk of lymphoma over the general population. And they're particularly at increased risk of malt lymphomas, which makes sense because those are the lymphomas that we see arising in conditions of chronic inflammation. And the distribution, vast majority of these are going to be in the parotid, but they also do occur in the submandibular gland. And then you can see sublingual and minor salivary glands very rarely involved by lymphoma. And the most common types, there are 3 types that make up the majority and about 25% each. So malt lymphoma, we already discussed, that tends to occur in the setting of chronic sialadenitis, particularly in patients with Sjogren's syndrome. But you can also see primary follicular lymphomas, and you can also see diffuse large B-cell lymphomas. And DLBCL can occur either de novo, let's say in like one of the parotid lymph nodes, or it can arise from one of these other lymphomas, follicular lymphoma or malt lymphoma. All right, so you probably have already seen this image as well if you went to my GAP talk, but this is a fun image that I like to show just to remind you that lymphomas can have quite a heterogeneity in terms of their radiology. So both of these are MRI images, and the question is which one of these is lymphoma. Here we have a very circumscribed lesion here on the left, on the right side of this patient, but the left side of your screen, we see this lymphoma, which is relatively well circumscribed here. And then we have this lesion on this other patient, which is very poorly circumscribed. It's sort of moth-eaten, looks like it's partially cystic, partially solid. And the reality is that both of these are lymphoma. So this follicular lymphoma is arising in a lymph node, which is why it's so well circumscribed. Malt lymphoma, on the other hand, arises in the background of chronic inflammation. Patients with Sjogren's syndrome tend to have what are called these lymphoepithelial lesions, where the lymphocytes attack the ducts. And then because of that, they get all sclerotic, and then downstream of them, you get the cystic dilation. So patients with Sjogren's syndrome will tend to have this moth-eaten look anyway. So when malt arises in that background, it'll tend to look very poorly circumscribed and moth-eaten. So just being aware of your patient's history and radiographic impression can give you an idea of what type of lymphoma to expect. All right, so now let's get into the good stuff, the juicy stuff, and we'll talk about epithelial tumors of the salivary gland. So this is the 2017 WHO, and as you can see here, here are the malignancies, here are the benign epithelial tumors of the salivary gland. And there are just a ton of these things, and we're not going to be able to talk about all of them today. I'll try to touch on the most important ones, most frequently seen ones. But if you're going to be signing these things out in the future, you're just going to have to buy the WHO and just try to digest these things. Anyways, 23 carcinomas, 11 benign neoplasms. We'll try to get through as much as we can. And the reason that there's so many different types of lesions in the salivary gland is that there are just all these different cell types. And each one of these cell types can give rise to at least one and frequently multiple different malignancies. So knowing which cell gave rise to the tumors can also give you an idea about what immunohistochemistry to use. For instance, acinar cells are positive for DOG1 and SOX10. So acinic cell carcinoma will be positive for both of those. SOX10 also stains intercalated duct cells, so all of these lesions should be SOX10 positive. And then if something arises from basal or myoepithelial cells, they can show those markers. So, SMA, S100, calponin, P40, P63, all of those things. All right. And then one thing which is sort of cool is that myoepithelial cells are just bizarre cells. They're quite interesting. So they can have a very wide array of morphologies. So they can be spindled, like you see here. These are all myoepithelial cells. And they can be epithelioid. They can be plasmacytoid. In this example, we're also seeing some plasmacytoid cells here. So these are not plasma cells. These are actually myoepithelial cells here. And they also can secrete all these bizarre matrix type materials. So here we see this dense pink hyalinized stuff. That's all being secreted by the myoepithelial cells. And this is actually a high power picture of a pleomorphic adenoma. This is another higher power picture of the same lesion. And again, just showing you, these really look like plasma cells. It almost looks like a perinuclear huff here, but these are all myoepithelial cells. So just being aware that they can have quite a morphologic diversity will help you when you're approaching these lesions. Other thing which is sort of interesting about salivary gland is that there are quite a lot of tumors that are biphasic. So they have both ductal components as well as a basal or myoepithelial cell component. So these are the 5 lesions that are biphasic. They're all sort of in the minimal cytoplasm, more like basaloid tumor kind of category. So you can see most of these cells don't really have much cytoplasm. They look sort of bluish. But yeah, they're both ducts and myoepithelial cells. It's extremely interesting, but both of these cell types appear to be neoplastic. Just to highlight that for you, here are the ducts. You can appreciate the ducts, and all the other cells surrounding these are myoepithelial cells. So we'll talk about some of these lesions a little bit more later. Okay. Another thing about salivary gland. So there are several tumor types where the diagnosis of malignancy is based on the presence of invasion. So you actually have to see invasion to diagnose malignancy. And these are the tumor types. So basal cell lesions, myoepithelial cell lesions, and oncocytic lesions. So basal cell adenomas and adenocarcinomas, you're going to see a biphasic population of basaloid cells. And really, it just boils down to whether one is invasive or not, whether you could call it malignant. For these lesions, it's just a pure population of myoepithelial cells. And the question is it invasive or not? Obviously, if you have a bunch of mitoses or some atypia, you might want to look harder. But the diagnosis of malignancy is really based on invasion. And same thing for oncocytic lesions. And so that's something to keep in mind as you're going through these. There are other lesions which are defined purely by genetic abnormalities or whatever, but that's not the case here. And I like to show these images because for all of these lesions, the malignant counterparts can be rather bland looking. So you may have seen this before, but I do like to tease people with this. So if you look at this, we have pure population of oncocytes, right? These are very pink cells with granular cytoplasm, really abundant granular cytoplasm here. So these are pure populations of oncocytes, both on the left and right. Now, one of these is benign and one of these is malignant. And really, you can't tell at this power. It's really impossible to say which one's going to be benign and which one's going to be malignant. But if we zoom out, we see the one on the left actually is completely circumscribed and has a very thin capsule. So this is an oncocytoma, whereas the one on the right is infiltrating. So this was an oncocytic carcinoma. Same thing here, we have biphasic population. Notice that we have ducts here. See these cells that are a little more lighter cytoplasm in the center here. And then we also have these basal cells surrounding them. So we have a biphasic population. There's a little bit of this cellular stroma. So these are basaloid lesions. So we have a basal cell adenoma and a basal cell adenocarcinoma. And at this power, it's really hard to say which one's going to be malignant. Zoom out, the one on the left was completely circumscribed. The one on the right is infiltrating. So this is malignant. So really, it all just boils down to looking at the periphery of these lesions to make sure they're completely confined before you call something benign. So especially for these lesions, I like to submit the entire thing. It's sort of similar to a follicular adenoma versus follicular carcinoma in the thyroid gland. Okay, so I'm going to be giving you a bunch of different cases soon, just to keep things interesting. I'm going to sort of jump around. So I decided I would put in this slide just to remind you of what the most common lesions are in the different areas. So for major and minor salivary glands, pleomorphic adenoma is always going to be the most common lesion. But for major salivary glands, particularly parotid, we tend to see Warthin tumors and basal cell adenomas, and those really don't occur in minor salivary glands very much. Particularly Warthin tumor. Warthin tumor is actually completely confined to parotid, and I'll show you why in a bit. And then when we look at malignant tumors, mucoep and adenoid cystic carcinoma tend to be the most common in both major and minor salivary glands. But acinic cell carcinoma is very rare in minor salivary glands, which makes sense because as we discussed, acinar cells or the serous type acinar cells are most common in parotid and then become less common as we move to the minor salivary glands. And then there are a bunch of tumors that are pretty much exclusive to minor salivary gland, including polymorphous adenocarcinoma. And some people, depending on the series, you can see polymorphous adenocarcinoma as the second most common minor salivary gland carcinoma. So just a reminder, there are some tumors that are almost always in the major salivary gland. These are those tumors. And then there are some that are almost always in minor salivary gland. We already discussed polymorphous adenocarcinoma. There's also this really unusual lesion we'll discuss called canalicular adenoma. And then finally, clear cell carcinoma, which used to be called hyalonizing clear cell carcinoma. And all of these lesions, you really very, very rarely see them in major salivary glands. Okay, so this is just one of those classic super large slides, which is just confusing and terrible to look at, and it just annoys people when they put them in their talks. But I'm putting it in here just so you guys have it in the future. When you look at the slides, you can refer to this chart. These are all the genetic rearrangements that we see in salivary gland lesions. And this is, as far as today, everything that's been described, but there's probably going to be more things coming out in the future as well, because these things are being discovered all the time. Now, some of these are disease defining in the salivary gland, so I've highlighted those here. So all of these lesions, if you actually get the mutation, if you identify it, you can be very confident that you have that diagnosis. Pleomorphic adenomas do have a characteristic PLAG1 gene rearrangement, but remember, any carcinoma arising in pleomorphic adenoma will retain these alterations. So that's why I don't really consider them disease defining. But yes, all of these fusions and rearrangements you can consider pretty specific. All right, so then, as we go through these things, I'm going to give you one way to do it. There are multiple different ways to approach salivary gland lesions. I'm just going to show you the way I do it, the way I was taught to do it, and the way a lot of people do it. But basically, my approach is that you look at the lesion, and the first thing you're going to say is it pleomorphic adenoma or Warthin tumor? Because that's the vast majority of what we see. And if it is, you can sign it out, no problem. Though sometimes pleomorphic adenomas can be quite a problem. And we can discuss that when you rotate with us, but they're real tricky lesions. But anyways, if it's not one of those lesions, it's not super obvious, then you have to consider a differential diagnosis. And I use this, minimal cytoplasm versus abundant cytoplasm in order to create a differential in my mind. Okay. So let's talk about the bread and butter lesions. So we got PA and Warthin tumor. These are things I've actually asked your program directors, and they've assured me that if you don't know what these are, when you rotate with us, I am actually allowed to fire you. So I just checked to make sure before I gave you the lecture this morning. That is still true. I'm allowed to fire you if you don't know these. So pleomorphic adenoma, this is the gross picture of what pleomorphic adenoma looks like. So sometimes we'll cut in these things and you just know it's going to be a PA because it has this sort of gelatinous look to it. Almost looks like cartilage, and I'll show you why that would be the case. So it just has this circumscribed, but very nodular gelatinous look. And this is what it looks like on histology. So very chondromyxoid background. This is one that's very rich in stroma. Go to higher power, we see that we have ducts here, and then we also have cells lining the ducts and cells that are just sort of embedded within the stroma here. And then in other areas, again, we see that it looks like it's biphasic, right? So we see ducts, and then we see basal or myoepithelial type cells surrounding them. So it looks like it's a biphasic tumor. And then we do have areas here that are just basically cartilage. It's incredible. They actually are undergoing chondroid metaplasia, and we see cells embedded in them. And these are actually myoepithelial cells here embedded within this matrix material. So pleomorphic adenoma, you might also hear the term benign mixed tumor. And I guess it's mixed because it can have mixed amounts of cells and stroma. It can have different mixed types of stroma. So these things can really have a bunch of different appearances. So it is the most common salivary gland tumor, represents about 60 to 70% of salivary gland tumors, so very common. It's benign, we consider it benign, but they can recur. And there is this weird entity known as metastasizing pleomorphic adenoma. So I actually think that it's sort of weird that we consider these things benign because they can be really horrible tumors to manage, and they can really ruin people's lives. But anyways, we call it benign. So by histology, they're usually encapsulated, and they're biphasic. So you're going to see ducts, you're going to see myoepithelial cells, the 2-cell population. And then the stroma, which we discussed, which can be either this chondromyxoid stuff or it can be more hyalinized, and I'll show you examples of that. And then it's important to be aware of these little pseudopods. They're these things that sort of stick off of the tumor and jut out from the main tumor mass. And they're a big reason why these things can recur, because surgeons will sort of nip these things off and leave these left over in the patients. Molecular, they do have characteristic rearrangements. So PLAG1. Anybody know what PLAG1 stands for? Feel free to shout it out. This is where we're going to try to get a little more interactive.
Pleomorphic adenoma gene.
Yes, yes. Sharon,
Nice.
good job. So yes, pleomorphic adenoma gene. So you're not going to forget that one, right? So that's easy one to remember. HMGA2 is like homeobox, some other crap. I don't know. I can't remember it, but PLAG1 we should be able to remember. So again, if you don't know this when you come on rotation with me, I am allowed to fire you. So I'll probably fire you if you don't know that. All right, and then like I said, you can get recurrences in these. They, occur 3 to 5%, so not terribly common. But when they do recur, they can be quite disfiguring. And usually surgeons say they have like 2 chances. If you don't get it all out on the second try, then often these patients are just stuck with these for life, and they can be really horrific. And they can undergo malignant transformation and become carcinoma XPA. We'll spend a little bit of time talking about that. But yeah, so, if we diagnose these things on cytology, which we do all the time, they really have to take this lesion out. This is not one that you want to leave in the patients. So after about 15 years of these tumors being left alone, there's almost like an 8 to 9% risk of malignancy. So the longer they stay in the patients, obviously, the greater chance that they'll undergo malignant transformation. All right, so here's the histology. So here we have benign salivary gland here, and then we have this encapsulated lesion. And notice that it does have this sort of like nodular growth. It sort of has this pushing growth, but it's all retained within the capsule here. And we have different amounts of stroma and cellularity. So depending on where you look, you might have a bunch of different types of cellularity. When we go to higher power, we see that we have 2 different cell populations, ductal as well as the myoepithelial cells here. Another thing that you can see sometimes, which is sort of cute, is these little tyrosine crystals. They look like little flowers, as opposed to amylase crystals, which are more like daggers. So tyrosine crystals are a little cuter. And you'll just see them sort of floating around in this, chondromyxoid matrix material. Sometimes you can appreciate these on FNA as well, but they're not specific. You can see these in other entities as well, but just a cute little finding that you'll see. Other thing to be aware of, I'm not going to spend a lot of this talking about the various metaplasias that we can see in different lesions, because then we'll be here all day. But one thing that we see relatively commonly, so it's worth spending some time on, is you can get this squamous metaplasia and pleomorphic adenomas, and it's perfectly benign, not a big deal. So you can let this kind of thing go. It's probably just some weird reaction to injury. So here's another focus where you have a little squamous metaplasia. Here we see just the normal bland cells. These are probably myoepithelial cells here. And then just the squamous metaplasia, which is even keratinizing in this case. So if you see that atypical cells or anything, you can just sort of let that go. So I mentioned that recurrent PA can be a real horrific thing. And that's why I think it's sort of weird that we call these things benign, though they don't frequently metastasize. Anyways, this is a recurrent pleomorphic adenoma. This is just one picture I found on the internet. I mean, there are tons. In fact, there are some really horrific ones. But this kind of thing, it can be debilitating for patients, and you'll try radiation therapy and different other things for this when surgical management fails. But often these people are left with these tumors that are just disfiguring. So this is an example that we actually had here. This was signed out literally last week. I think Dr. McLean signed this one out last week, but I thought it was a good example. So this is some neck skin. So you see the skin here and then the fat, and then all of these nodules of pleomorphic adenoma lodged within this fat. So when you see this pattern, even if you don't have a history provided, of surgery for PA, you know that this is a recurrent PA.
Dr. Lubin, may I?
Yes.
It's really challenging to try to determine margins on a very nodular, multinodular process like that too. So I learned a lot signing that out.
Oh yeah, absolutely. And in general, they're hard to determine margins. And honestly, even if we say that margins are negative, they may not be, because like I said, there are these little pseudopods and you may not get them in the plane that you have on the slide. I wonder if I have a good picture of a pseudopod. I probably should have one here. Let me see. So this is actually sort of a pseudopod. I probably should get some better images, but you see these little things sticking off the tumor, and that's really common. So sometimes these things, will be left in the patient, and so yeah, margins can be a real mess in these. Okay, it's pretty.
Oh,
all right.
Carcinoma.
What's that?
Do you need to submit like a certain amount of a PA to rule out? Is there like a rule of thumb or
to rule out carcinoma in a PA?
Like when you're grossing, you have to submit a certain amount of a PA.
I'm sorry? You're sort of breaking up. Maybe you can type it. Type your question. Is that Patrick? Do we have a chat? Yes. Okay, type your question and we can try to address it. All right. Do you have to submit a certain percent of PA? Oh, okay. That's a good question. So there aren't good studies on that. But typically I would say when you do a PA gross, what you want to do is just slice it up and just do a typical gross examination. Look for any areas that might be concerning for necrosis or anything like that and submit those areas. But there isn't a good study on the percentage that you need to submit in order to confidently make a diagnosis of malignancy. Honestly, carcinoma XPA is pretty uncommon. So usually they won't be confined to the PA. There are carcinomas that are confined to the PA. But they're pretty uncommon. So we don't have to freak out about this too much. But yeah, I'd say just do a good gross examination when you're submitting any PA, and submit any areas that look unusual, because they'll usually be associated with things like necrosis or hemorrhage and stuff like that. All right, so let's move on. So carcinoma XPA. So these are usually older patients. So the mean incidence occurs in patients who are about a decade older than for PAs, which makes sense. And the classic history you'll get, particularly with, a boards question, is it's going to be this long history of slowly growing mass that they just don't really care about. They're just sort of letting it go. And then suddenly it's growing very rapidly and they have pain and facial nerve palsies and stuff like that. And there are specific tumor types that can arise in carcinoma XPA. We're going to talk about all these different tumor types. And you can see these. They'll have the same morphology and immunophenotype, whether they arise XPA or de novo. So yeah, the most common thing we see arising in pleomorphic adenoma is salivary duct carcinoma. And then the next most common is myoep carcinoma, and these can be very subtle. So these are ones you need to be careful of. And we can discuss that in more detail when you rotate with us. And then epithelial and myoepithelial carcinoma, which are a little more rare and sort of cool tumors. And the prognosis really depends on the extensive invasion. So if there isn't any capsular invasion, these tend to actually do quite well. And if they're minimally invasive, they also tend to do quite well. So if they're less than 1.5 millimeters, they basically act as though they're non-invasive. So this is a figure from an article by Nora Katabi and all the folks at MSK. And you can really see a wide difference in the disease-free survival rates between the minimally invasive and non-invasive group, as well as the widely invasive group. So, if you do diagnose carcinoma arising in a PA, you're not done. You have to first specify the type of carcinoma, and then you have to say whether it's non-invasive, minimally invasive, or widely invasive. So here's an example of, at least on this image, something that's non-invasive. So here we have the chondroid background with all the myoepithelial cells just sort of floating around in it. And then we have the carcinoma arising here with this comedo-type necrosis. So this is actually a salivary duct carcinoma arising in a pleomorphic adenoma. So hopefully you'd be able to appreciate this grossly. To get to Patrick's question, this is the kind of thing that you would be able to appreciate as this yellow, gritty cut surface. All right, so we can spend a little bit of time here talking about Warthin tumor. So these are really cute little guys. Grossly, they're pretty gnarly. They have what's described as like a motor oil fluid within these capsules here, or these little cystic lesions. And our surgeons have a lot of fun cutting these open and seeing all this motor oil spill out of these lesions. So actually Azim sent me a slow-mo video of him cutting one open just last week. I thought about including in this talk, but it's about a minute long of watching the stuff ooze out, and I didn't want to waste your guys' time. But anyways, when you see these things grossly, you usually know what it is because they have this really gross cystic stuff with all this motor oil.
Dr. Lubin?
Yeah.
I apologize. I genuinely have a question. Going back to carcinoma XPA, do we ever use the term in situ when something is non-invasive like that?
I mean, you can. I don't think I've used that term, but okay. You certainly can. I believe this is the terminology that the WHO uses, but I think they would get the same, they would understand what you mean by that. Okay. But as far as I know, there wouldn't be any difference between non-invasive and in situ. Like, I think you could use the terms interchangeably, and I can't imagine a way that one would be different from the other. But I'm not sure. Yeah.
Thanks.
I feel like I've heard some people say carcinoma in situ. Anyways, I say non-invasive, but it doesn't really matter as long as they know what you're talking about. All right. So this is what a Warthin tumor looks like on low power. So these are circumscribed, and they will be rich in lymphocytes. And then we can already see this sort of cystic change here with all this grungy crap. And this is the motor oil right here. Then we go to higher power, and we can see that these cysts are lined by this beautiful pink epithelium here. And I'll show you what that looks like on higher power. And then of course we have this dense lymphoid stroma. So here's the high power. So the Warthin tumors, you'll have a bilayer. So this is specific for Warthin tumor. There's a lesion that I'm not going to talk about today called a Warthin-like mucoepidermoid carcinoma. Not very common, but they can look very similar to Warthin tumor. But the one thing that they will not show is this classic bilayer. So once you see this, you know that you're dealing with a Warthin tumor. And the bilayer will show, first of all, these are oncocytes, right? So these are cells that have this really granular pink eosinophilic cytoplasm. And that's because these are really rich in mitochondria. So that's what oncocyte is, a cell that's rich in mitochondria. And we have this luminal layer here, and these cells tend to be very hyperchromatic. And then this basal layer here, and these cells tend to have a little more oval-shaped nuclei, a little fainter chromatin, and these little pinpoint nucleoli. So you can even tell cytologically the difference, but also just architecturally, these are clearly luminal, whereas these tend to be more basaloid, though they do sort of jump up a little bit here. All right, so benign masses, as we said, these are fluctuant because they're full of that fluid, and these are occasionally painful, and that's for a couple reasons. First of all, they can infarct. Anything with oncocytes can infarct. You might know in the thyroid, we see infarction of Hürthle cell adenomas very frequently after a fine needle aspiration. Same thing can happen in Warthin tumor. So particularly after you FNA them, they can become painful because they infarct. The other thing is that they're so cystic and they have this like fluid in it that if you compress it, you can squeeze that fluid out and it can go into the surrounding parenchyma and induce inflammation. So this is one of the few benign tumors that can present with a decent amount of pain. And so that's just, something to keep in the back of your mind, and also something they may throw at you on the boards. So these occur in older patients. There's an equal gender distribution. It used to be that these were far more common in men, but in the past 30, 40 years, women have started smoking to the same rates. So we see a similar number of Wharton tumors in women. And there is a strong smoking association. So it's like 10 to 1 increased risk of developing Wharton tumor if you smoke. So the vast majority of these things will occur in smokers or people who live with smokers or, see a decent amount of smoke exposure. So they occur in the parotid
Quick
gland.
question.
Yeah.
Is there any evidence whether vaping shows a similar risk factor?
That is a good question. And so far, I have not seen any reports of them being associated with vaping. So that's not an endorsement of vaping, but as far as I know, there haven't been associations with vaping yet. I would like to see what vaping will be associated with. Other than that vaping associated lung injury thing, I'm sure there's going to be some other things that all these vapors are going to get. So stay tuned. That'll be another 20 years down the line. But no, I haven't seen that yet. I haven't seen that reported for Wharton tumor. But that's a good question. Oh yeah. So anyway, so they're in the parotid gland, and they're often multiple. They're frequently bilateral, and they arise in intraparotid lymph nodes. This was something that was debated for many years, and then Dr. McLean and Dr. Bishop, Dr. McLean, that you know here, our current instructor, Annie, she did a study where they actually proved that they arise in intraparotid lymph nodes. So she can talk all about that when you rotate here. And they're extremely FDG avid on PET scans. And I'll discuss that in a little bit. Does anybody actually know why they might be FDG avid? Anybody who I've told this to, remember? Going once. Going twice. All right, we'll discuss it. But just remember, we're going to see a lot more of these things because we're doing a lot of PET scans. So they're going to show up incidentally, particularly in smokers, right? Because smokers get cancer, so then they get PET scans. Okay, and we discussed the motor oil fluid on gross, and we discussed the two components, the oncocytic epithelium and the lymphoid stroma. So again, just a few more pictures just to drive the point home. Very circumscribed, lymphocytes, pink epithelium. No question, we got a Wharton tumor, super straightforward. Same thing here, very circumscribed. All right, so this is the answer to the question. So why are these things FDG avid? So this is a picture of a Wharton tumor that we had here that was discovered on PET scan. And that thing is lighting up, man. I mean, these things will have an SUV that's frequently higher than the original carcinoma that they're working up. And the reason is that the oncocytes are just loaded with mitochondria, right? So they're metabolically active. So you put this glucose, that's what this FDG is, in there, and they will suck it up and just really start pumping out all the ATP like they're supposed to do because they're, mitochondria-rich cells. So we're going to find a lot of these things incidentally. And if you're wondering whether this holds true for other oncocyte-rich tumors like Hürthle cell adenoma and Hürthle cell carcinoma, yes, it's true. They are FDG avid, very FDG avid. Same thing for oncocytic sinonasal papillomas. And that's something that we're going to be publishing soon. All right. So let's see, what time is it? It's 8:25. We have about 1 hour left. Do you guys want to take a break? How does it usually work? We can take like a 5-minute break and then we can just do the rest after that, or I'm happy to just keep going, whatever you guys want.
Hey, I would appreciate a 5-minute break.
All right, yeah, cool. Let's all get our stuff together, go get some coffee, go do your business. So let's see, right here, I got 8:25, so we'll start again in 5 minutes, 8:30.
Thank you very much.
All right, cool. Right on. Okay, so here we go. So we just left off talking about PAs and Wharton tumors. So now we're going to get into some of the other interesting entities. And these are a little more exotic tumors. Things are probably going to get a little more weird and confusing, but also a little more sexy. So I encourage you to ask questions as we go through things here. So I actually really enjoy when you guys ask questions. It makes it feel like I'm not just talking into the void and just, insane here in my office. So please feel free to ask questions as we move along. All right, so we're gonna first talk about tumors with minimal cytoplasm. These are tumors that sometimes people refer to as basaloid. These are all tumors that can have sort of a bluish appearance because of their relatively high NC ratios. So this is the differential that I consider for these lesions. And when I call things low grade, intermediate grade, this is sort of like the default grade of these tumors. Any of these tumors can become high grade, undergo high grade transformation. That's not something we're going to really talk about in this talk, but these are sort of the default grades of the tumors, unless we see something like necrosis, increased mitoses, and a lot of polymorphism. Then we can sort of bump these up a grade or two. And then remember, as we go through this, that there are 5 of these lesions that are biphasic. So when you approach these, some of these things will be on the differential with each other, but once we prove that something's biphasic, it can narrow down the differential. All right, so let's just jump right into the cases. So first case we have here is a 60-year-old woman, and she has an upper lip lesion. All right, so let's resect this sucker, see what we got. We got some squamous mucosa up here, right? And here's a little minor salivary gland tissue here, and then here's our tumor. So it's variably cystic and solid in some areas. So you have all this proteinaceous sort of crap here in the cyst. And then when we look at the solid components, we see that we have cells that are somewhat basaloid. So they have high NC ratios. They're somewhat bluish. And they're growing in these interesting sort of anastomosing tubules here. And they have this almost sort of like columnar appearance in some areas. And here you can see that the cells are sort of reaching across these little tubules and sort of kissing each other right here, a phenomenon known as beading. This cute little beading here going on where they're sort of reaching across the aisle, you know. So cute little guys. Here's another little picture, and it looks like this is actually a single cell population, right? So all we see are these columnar cells. We don't really see any other, like, you know, basal or myoepithelial cell layer. And again, they're doing this cute little thing where they're reaching across and kissing each other. So cute. So you guys know what this thing is. This is an exotic one. So you'll get
Canalicular adenoma.
Yes, well done. Who was that?
It's yummy.
Very good, Yamin. Very good.
Nice,
Yes,
Yamin.
this is canalicular adenoma. That is very impressive. You're on my Hall of Fame list forever. Very well done. So yes, this is canalicular adenoma. So this is very rare, less than 1% of all salivary gland neoplasms. Actually, you know, we only have a handful of these in our files, and every institution you go to will only have a handful. When I was at Penn, I looked through about 10 years worth, and I came up with 2 or 3 canalicular adenomas in about 10 years there. It's a pretty active center as well. So these things are very, very rare. And they occur in middle-aged elderly patients. There's this weird, now all salivary gland lesions, or most, tend to occur more frequently in women, but canalicular adenoma has a more prominent female predominance for some reason. And the interesting thing about these things, they tend to occur in the upper lip. So they're almost always minor salivary glands, you know, like 99% will be minor salivary glands. But of the minor salivary glands, you know, somewhere around like 80% or so will be the upper lip. And then they also occur on the palate, buccal mucosa, stuff like that. And by the way, I have no idea why it occurs on the upper lip, and I haven't seen anybody propose a good theory as to why they should occur there more frequently. So by histology, we sort of saw it. They tend to be circumscribed. They're sometimes multifocal, which I'll show you. And it is a single cell type. They're columnar cells, and they have these cute little anastomosing tubules. They have this beading phenomenon where they reach across the aisle and smooch each other. And they can have what's called squamous differentiation. I actually think that's sort of misleading because it might be sort of squamoid, but I'll show you what I mean by that. And then this loose bluish glycosaminoglycan rich stroma. And in terms of IHC, they're positive for cytokeratins, S100 and SOX10, and negative for other myoepithelial markers. So it's actually not clear what cell type these are really derived from. So here's another picture of a canalicular adenoma on low power. So even though the lesion is relatively circumscribed here, we can also see that there's something going on here. And if we go to higher power, we can see here's the main lesion. And then there are also little suckers sticking out here into the remainder of the salivary gland. So this is what we mean when we say multifocal. And it's sort of unclear why this happens, whether these are distinct lesions that are arising in adjacent salivary gland parenchyma, or whether this represents, tumor traveling down some tubules or ducts or something. It's sort of unclear. But anyways, it can have this sort of multifocal nature. But as long as it's canalicular adenoma, you don't have to worry that you're dealing with a malignancy. And then again, beautiful canals, hence why it's called canalicular adenoma, or tubules with this cute little beating phenomenon. And this is that sort of like squamoid morules. I don't really like calling these squamoid morules because this doesn't really look squamous to me. But this was described by Lester Thompson. He and I think it was Dr. Mueller actually did the largest series of these. And they described this phenomenon in I think it was something like half of their lesions, where you get these weird cells that jut into the lumen and tend to be a little bit more eosinophilic cytoplasm. And these will actually be positive for P40 and P63. So that's probably why they call this sort of like squamoid morules, but they really don't look too squamoid to me. All right, next case. So we got a 65-year-old woman and she has a parotid mass. All right, let's take a look at this sucker. All right, so we've resected it and it looks pretty frickin' circumscribed, right? It almost has this nice thin capsule and it looks like it's respecting it. So we got a circumscribed lesion, which is encapsulated. All right, now let's go to higher power and we see, okay, we see one cell type here, it looks like, these sort of lighter cells, more clear cytoplasm. And then it looks like there's another cell type lining these cells. So it looks like this might actually be biphasic. And then we also have this unusual stroma, which is very cellular here. So let's do a couple stains. We see that these, the basal type cells are P40 positive, and the inner cells are positive for CAMP 5.2. So you could do other ductal markers, CK7, we'll highlight these as well. But in any event, we clearly have a biphasic population of cells that look somewhat basaloid, and it's a circumscribed lesion. So what should we call this thing?
Basal cell adenoma.
Yes, Milad. Yes, basal cell adenoma. Nice, good job. So, yep, this is a benign, slowly growing tumor, pretty rare, represents 2 to 3% of salivary gland tumors. And it's a wide age range, but it usually is older patients. And like a lot of tumors, there is a female predominance. And we just saw the histology. It's circumscribed, it's usually encapsulated, and it'll be a biphasic population of ducts and basal cells. And they can grow in various types of architecture, solid, tubular, or trabecular. There's also a membranous architecture, which I'm not going to discuss today because I think it's sort of a different entity, and that might be sort of broken off from basal cell adenoma in the future. But just know there's this membranous variant of basal cell adenoma out there. And then they can have this cellular stroma, which we saw there. And then for immunohistochemistry, you can do stains to highlight the dual cell population like we did on this case. And then the other thing you can do, which is more specific for basal cell lesions in particular, is LEF1 and beta-catenin. And by molecular, these things will show beta-catenin mutations in around 60% of cases. And very good prognosis. It's very rare for these things to recur, and they don't metastasize. So here's basal cell adenoma. Again, we have this sort of biphasic population. Sometimes it's relatively hard to appreciate, but you can always do the stains to highlight that. All right, so now let's, I'm sorry?
What is your favorite myoepithelial marker?
Well, so I don't really have a favorite, but I do have like tears. And I learned this from your boy, Dr. Bishop. So he does like several stains as to begin with, and then he'll do additional stains if those stains don't work out. So in your first tier, you have SOX10, P40, and SMA. And if those stains don't work, but you're still convinced that you have myoepithelial cells, you can do other things like calponin, GFAP, CK56. I think that's S100. But yeah, there are a bunch of different IHC, different types of IHC that you can use, and depending on the morphology of the myoepithelial cells, they'll have a different staining profile. So plasmacytoid cells tend to stain with certain markers over others. Spindled cells tend to stain with certain markers over others. And I honestly can't remember how each one of those different morphologies stain, but they all stain in a unique way. So that's why you often need multiple different markers for myoepithelial cells. But yeah, it's a good question. Because sometimes you'll do, if you do just one stain, like I know some people who say, oh, I just throw an SMA on it. If it's negative, I know they're not myoepithelial cells, but that's not really true. You have to throw a bunch of stains on them.
Awesome. And you have a question in the chat too.
Oh, chat. Let's chat. Oh, that's a really good question, Brian. So Brian's asking if, Annie, nah, we can, don't offer your services, and just we can fire them. Just let me fire them. So to answer Brian's question, to answer Brian's question, that's a really good question. And no, no, there aren't any described molecular abnormalities in canalicular adenoma, but you get the feeling that there must be something. I actually was asking Annie about this recently because she talks to Dr. Bishop, Justin Bishop at UT Southwestern relatively frequently. And apparently he has tested at least one canalicular adenoma he sequenced, and he didn't find any abnormalities. But I was wondering whether he actually, like what type of sequencing he did. Because, it could be that these are translocations, which might not be picked up unless he did, reverse transcription kind of thing. Anyway, so I think that that's probably one of the lesions where we're going to discover down the line some kind of classic genetic abnormality. Part of me is sort of interested in just using my funds and just sending them for Archer and seeing what shows up. But the reality is that it probably won't be of too much clinical use because they're so distinctive morphologically that there usually isn't that much question about the diagnosis of canalicular adenoma. And that's probably why it hasn't been described yet, is there just isn't much of a need to describe the molecular, but that'll probably be something that'll come out in a couple of years, and then I'll slap myself for not having looked into it myself. All right, so that's a good question. All right, 70-year-old man with parotid mass. Let's look at this lesion grossly. So it looks relatively well circumscribed. So here's the normal salivary gland parenchyma. Here's your lesion, relatively well circumscribed, but here it's unclear. Like, is it invading? Can't really tell. It almost looks like it might be infiltrating. And then we look at the histology and we can see it does look like it's infiltrating, and it's creating this neocapsule around it. Here we see some more infiltration down here. And then we go to higher power and we see sort of a similar thing to what we were seeing in the last tumor, the basal cell adenoma, where it's a very basaloid population, meaning very high NC ratio. And then on higher power, we can see that it really does look like there might be ductal component and then a basal cell component surrounding it. And then there's this stroma is a little bit less cellular, but there is some cellularity to the stroma here. So we do our stains to prove that it is truly biphasic, and we can see P40 nicely highlighting the basal cells, but sparing the ductal cells. And then conversely, the CK7, and this is absolutely beautiful, highlighting the ductal cells here and sparing the basal cells. So this is a basaloid tumor, which looks very similar to the basal cell adenoma, but it's infiltrative. So what do you think we should frickin' call this thing? Oops. I mean, I don't have to ask that question. You guys know. So this is a basal cell adenocarcinoma. So this is very rare. I think you get like 1/3 the number of basal cell adenocarcinomas per basal cell adenoma. So even more rare than basal cell adenomas, which are already quite rare. Really wide age range, but these usually tend to occur in older population. And there actually is a relatively equal gender distribution. Vast majority of these will occur in the parotid, which is similar to basal cell adenoma, but you can get some in the submandibular gland. They basically don't occur in minor salivary glands. And the histology is really basically the same thing as what you see in basal cell adenoma, except it's infiltrative. So remember, this is one of those 3 types of lesions where the diagnosis of malignancy depends on invasion. So basal cell lesions, myoepithelial, so myoepithelioma and myoepithelial carcinoma, and then oncocytoid lesions or oncocytic lesions, oncocytoma and oncocytic carcinoma. So really it's just, is it infiltrative or not? So interestingly, these will occasionally show PIK3CA mutations, but they don't tend to show the beta-catenin mutations that we see in basal cell adenomas. So we'll talk about that a little bit. And IHC is the exact same as basal cell adenomas, so IHC won't help you here. Prognosis is actually pretty good. So they commonly will recur in anywhere from 20 to 40% of cases, but it's very rare for them to show metastatic disease. And when they do met, it's usually to cervical lymph nodes and rarely will be distant. So you're probably not going to die from this tumor. So here are some more examples. So notice that it has this sort of pushing infiltration and it's encapsulated here. So that's very different from some things that might be on the differential, like adenoid cystic carcinoma, which isn't encapsulated. Those things are just widely infiltrative. This more has like the type of invasion pattern that you would see with something like a follicular carcinoma of the thyroid, where it's sort of like pushing, as opposed to like PTC, right? Which is more infiltrative. That's sort of like the adenoid cystic carcinoma kind of thing. Here's one that has more of a solid architecture here, but if you were to do the stains, you would see that this is also a biphasic population where there are some ductal cells sort of scattered throughout. And I sort of alluded to this, basal cell adenoma and adenocarcinoma have distinct molecular alterations. So in this study, we have 5 basal cell adenomas that they sequenced, and 4 of them showed beta-catenin mutations. And then you can compare that to the 1 basal cell adenocarcinoma, which had a PIK3CA mutation and then a bunch of other mutations, but did not have the beta-catenin mutation. Oops. And then we move on. This is another study. So all these up here are basal cell adenocarcinomas. And you can see one of these had a PIK3CA mutation. And then we compare that to basal cell adenomas, and these tend to show beta-catenin mutations. And this is the variant that I was referring to, a basal cell adenoma, the membranous variant, which tends to have greater likelihood of relapse and has different mutations from typical basal cell adenoma. So I think this is actually a different lesion and might be separated from basal cell adenomas in the future. So because they're genetically distinct, you might think that maybe you could distinguish them by IHC, but like I said, you really can't. They stain exactly the same. So even though basal cell adenomas have beta-catenin mutations and basal cell adenocarcinomas do not, they both show the same staining profile for beta-catenin. So around 40-something% of each of these will be positive for beta-catenin. So you really can't use that to distinguish them. Similarly, LEF1, which also stains both basal cell adenoma and basal cell adenocarcinoma, it's going to be positive to the same extent, around 70% in both of them. So stains aren't going to help you in this differential. The one thing that the stains will help you with is if you have like a small biopsy, let's say, positivity for one of these markers would suggest a basal cell lesion as opposed to something like an adenoid cystic carcinoma. All right, next case, 45-year-old woman with a parotid mass. So I stole this from Ben from Twitter, this beautiful image. It was just too good. Hopefully someday I'll get my own gross image, which is this good of this lesion, but this is just classic. So here we have normal parotid, and here we have the tumor. And we see the tumor here is infiltrating into the normal parotid. It doesn't really look circumscribed. It's quite infiltrated. There's a decent amount of hemorrhage. It has something of like this almost gelatinous sort of glistening look in some areas. And we cut into it, and this is what we see on histology. So we see very cribiform architecture here. And there's this sort of bluish glycosaminoglycan type stroma here. We see a little bit of retraction of the tumor cells from the surrounding stroma of, other tumor stroma here with the cellular stroma. And then let's go to another image here, and we see, again, the sort of cribiform architecture here. Here they look a little bit more tubular. We still have abundant amounts of this sort of like bluish glycosaminoglycan type stroma. And then higher power, we see that it actually does look like this is a biphasic population. So we have here, these are the ductal cells, right? So they're a little bit more eosinophilic. The nuclei are a little bit more oval, and you can even see these little pinpoint nucleoli. So ductal cells here, ductal cells here, ductal cells there. These are nice ductal cells. And then we have these other cells, which are sort of angulated, hyperchromatic nuclei, really don't show much cytoplasm at all. Some of them look sort of like carrots. So two different cell types. Here's another area where you can really see the two cell types highlighted very well. So again, ductal cells, they look more eosinophilic because they have a little bit more cytoplasm, which is a little pink, and they have round nuclei. They can show prominent nucleoli. And then compare that to the other cells, which are the basal myoepithelial type cells, which are these hyperchromatic sort of angulated guys. These are the carrots. One more picture. So the one thing that when I was first learning about this lesion, I used to think that these big spaces here were the ducts. They're not the ducts. Again, these are the ducts, these tiny little things here. These are just weird, cystic spaces that just get full of this stroma. So then we go to a high power of this cribriform structure, and we have all these little spaces that are filled with this stroma, but then we see a nice duct here. So these are the ductal cells, and then all the rest of these cells are basically the myoepithelial type cells here. These might be ductal cells here, it's hard to say. And these are ductal, but really the rest are probably myoepithelial cells. All right, so what is this tumor? You guys should know this. I could probably fire you if you don't know this.
Adenoid cystic carcinoma.
All right, Ali, well done. Yes. So yes, adenoid cystic carcinoma. So this is a malignant tumor. It's usually slowly growing. So this isn't going to be something that arises overnight. This is going to be something that patients will present with months of a slowly growing tumor. Occurs in all ages. This can happen in kids too. It's most commonly in young middle-aged folks, approaching my age, I guess. So unfortunately, I'm in this category. And there's a slight female predominance. So this is one of those tumors that occurs in both major and minor salivary glands. So this can happen pretty much anywhere. It happens in the trachea. It's relatively common there too. So you'll see these all over the place. You see them in the breast, you see them in the gyne tract. So it's really all over. And by histology, the one thing that's more specific is that you have these angulated hyperchromatic carrot type nuclei. And it is a biphasic tumor. So remember, you will have the ducts as well as the myoepithelial cells. There are three different types of architecture. There's this cribriform architecture, which we saw, tubular architecture, which we also saw, and then a solid type, which I'll show you a little bit later. And then the stroma, like I said, there are two different types. There's this pink basement membrane type, and then there's this bluish glycosaminoglycan type. But you usually see decent amounts of stroma as well. And then perineural invasion is super common. Like if you don't see perineural invasion, you got to wonder if you're even dealing with the right tumor. And in fact, these often show intraneural invasion, which I'll show you as well. And there was a study by Bin Zhu and Nora Katabi at MSK that came out a few years ago, which found that any solid component is associated with a worse prognosis. So for these, I would suggest that you should probably just look around for a solid component and just report the percentage of a solid component. If it's greater than 30% solid, you can just flat out call it solid variant, and that's associated with a far worse prognosis, but any solid component is bad. And these have a characteristic translocation. So MYB and NFIB, which is seen in about 80% of tumors. And then there are these other various types of fusions that you can see as well. But by far the most common are MYB, NFIB. So this is the stuff you'll be tested on. And the prognosis of this is actually really quite bad. But it's a slowly progressing tumor. So we'll have frequent recurrences. So if you look at it, the 5-year survival is actually quite good. It's around 90%, but 15-year survival suddenly is down to 40%. So this is something that unfortunately is often lethal, but it's usually lethal over the course of many years and is sort of characterized by frequent relapses, multiple surgeries. They're really, really unfortunate tumors. So this is what they look like on low power. So you can see this thing is quite infiltrative here. And we can even on this power appreciate that there's all this dense hyaline type stuff here, and then more bluish areas that has the glycosaminoglycan type stroma. Here's a higher power where we can see both types of stroma again. So this pink hyalinized stuff, as well as this bluish sort of amorphous stuff. And then of course we see the nice sort of cribriforming architecture here, and then the tubular architecture here. Even on this power, you can appreciate some ducts. So notice that you have a little duct here that looks a little more eosinophilic. Duct here, duct there, duct there. So you can really appreciate them. And then let's see, we can appreciate here's a little duct in the cribriforming structures, but sometimes it's harder to appreciate in the cribriforming architecture. Another picture, cribriform, tubule, lots of ducts. So I think you're starting to appreciate here probably the morphologies. And then again, this dense stroma in the background. Here's an image of a case we had last year, which was really infiltrated into the hard palates. This is a maxillary bone here. And you can see this is the overlying squamous mucosa. And this tumor is just chewing into the bone. On high power, you can see classic cribriform structures and some tubular structures of adenoid cystic carcinoma. And then just some more pictures, again, ducts. And then these carrot type hyperchromatic cells and this weird amorphous material. Don't forget about the retraction that you can see here of the tumor from the surrounding stroma. And then always look for the perineural invasion. It's going to be super common. And this is probably the reason that these things are just so hard to manage, because surgically they're just always all over the nerves. So it's going to be really hard to get this whole thing out. And then here's a case we had just a couple weeks ago where it had some beautiful intraneural invasion as well. So we have perineural as well as intraneural. And this is relatively characteristic for this lesion. This is solid variant. So you could imagine that this may have been a duct at one point. These may have been cribriforming structures, but now it's just solid sheets of tumor cells. So this is solid variant, and any amount of this is associated with a worse prognosis. Here's a nerve that's being demolished. All right, so let's get to the next one. This is on the differential diagnosis for adenoid cystic carcinoma. So we have a 60-year-old female with a soft palate ulcerated lesion, which we see right here. She's opening her mouth here. You can see this ulcerated lesion. And it almost looks like it's occurring in the submucosa. So see how it's sort of glistening here on the surface? That sort of suggests that it's probably a submucosal lesion rather than a surface-derived lesion like a squamous cell carcinoma, which usually won't have this kind of glistening appearance. All right, so let's look at the histology, and we can see here we have the overlying squamous mucosa, we have some minor salivary glands here, and then we have the tumor. And it is infiltrative. You can see it's sort of infiltrating into the minor salivary glands. But in some areas, it looks sort of circumscribed. Now let's look at higher power. So we go to higher power and we see here are nerves. So there's clear perineural invasion. There's no question this thing is malignant. Notice the unusual pattern that it's doing here. It's got this sort of like swirling pattern around the nerves. And that's somewhat characteristic of this lesion, though it's certainly not specific. Go to high power again, and we can see that these structures are sort of cribriforming, right? And then we also have these sort of tubule structures in the background. So architecturally, it's very similar to adenoid cystic carcinoma. But then we go to higher power, and one thing that should immediately stand out to you is that we're not really seeing those carrots. These cells are not the hyperchromatic, angulated carrot cells of adenoid cystic carcinoma. These are more oval-shaped nuclei. They have more vesicular chromatin, so very fine, open chromatin. They almost look like papillary thyroid carcinoma if you're cytologically inclined. So, and we don't really see two cell populations, right? It looks like all these cells are this cell type. So it's not like we're seeing ducts and myeloepithelial cells. So what is this?
Polymorphic adenocarcinoma?
Yes, Ali, you're doing great, man. Oh my God. You got to do head and neck pathology. I don't care what anybody else says or what you want. I don't care what
Way to
you
go,
want.
Ali.
You're coming to our side, man. You're coming to the dark side. So yeah,
It's
polymorphous adenocarcinoma. So it's a wide age range. Again, females more commonly than males. For some reason, that tends to be the case in salivary gland lesions. These are almost always minor salivary glands, and majority of them will occur in the palate. So unlike adenoid cystic carcinoma, which occurs in both major and minor, these are almost always going to be minor. So I've seen one case in a parotid, but gosh, the vast majority are going to be minor salivary glands. Histologically, they're unencapsulated, though, as in the last example, they're often somewhat well circumscribed, and they're monophasic. So it's only one cell type. We don't see ducts and myoepithelial cells. And unlike adenoid cystic carcinoma, they also are very bland cells with vesicular chromatin and sort of oval nuclei, as opposed to the sort of angulated hyperchromatic thing that we see with adenoid cystic carcinoma. And they show a variety of growth patterns. And that's actually why it's called polymorphous adenocarcinoma. I mean, it's not like the cells themselves are polymorphous. The cells are actually relatively monotonous, but they have a bunch of different architectures. So that's where that name comes from. So by immunohistochemistry, they're cytokeratin positive, of course, because they're epithelial cells. They're also positive for S100. But what's unusual is that they are positive for P63, but frequently negative for P40. This isn't always the case, but this is a very unusual pattern because if you know about P63 and P40, they stain different isoforms of the same protein. So it's very unusual for something to be positive for P63, but negative for P40. And I'm not entirely sure why it happens in this case, but it does. So this is a very unique characteristic. And by molecular, they're positive for PRKD1 mutations. It's not something that's tested very often, but that's something to be aware of. It's present in the majority of polymorphous adenocarcinomas. And interestingly, I'm not going to talk about it today because it's a little bit more upper level stuff, but there's this other lesion which used to be grouped with polymorphous adenocarcinoma called cribriform adenocarcinoma of the minor salivary glands, which looks very similar to polymorphous adenocarcinoma and stains sort of like polymorphous adenocarcinoma, but it actually has PRKD1 gene translocations as opposed to mutations. And it probably will be differentiated from polymorphous adenocarcinoma because those lesions tend to occur more towards the base of tongue. And they're associated with metastases, a higher risk of metastasis versus polymorphous adenocarcinoma. So it's something you may hear about in the future. Cribriform adenocarcinoma of the minor salivary glands used to be considered a variant of polymorphous adenocarcinoma, but I think it will probably be differentiated in future editions of the WHO, but we'll see. We'll see what the gurus say. So the prognosis for this is really good. So you'll occasionally have recurrences, around 15%, but metastases for polymorphous adenocarcinoma are pretty rare. So less than 5% will have lymph node mets. So really, it's important to distinguish this from adenoid cystic carcinoma. This is one where you really want to make sure you get the right diagnosis because it's the difference between saying you're probably cured with this surgery versus you're probably going to die of this disease. So you really got to make the right diagnosis here. So let's spend a little more time with it. So again, these are usually or almost always in minor salivary glands. So here we have the squamous mucosa and we have underlying tumor here. And you can see a little bit of this matrix material, very similar to what we see in adenoid cystic carcinoma, but notice it's all one cell type. Though in this case, they actually do have a little oncocytic metaplasia, which you can see in these things as well. Higher power, we see that they're very vesicular oval nuclei. So we're not going to mistake this for adenoid cystic carcinoma. Again, remember to look for this weird eye of the storm pattern. It tends to occur in this lesion. So that can be a tip off that that's what you're dealing with. And then lastly, remember, just look at the nuclei. They're oval, very fine chromatin. We're not really seeing all those angulated carrots. And then remember this unusual staining pattern. So P63 and P40 in adenoid cystic carcinoma is going to highlight the basal cell population or the myoepithelial cell population, right? But you're going to see a clear, both of them are going to be positive, and you're going to see a clear distinction between the ducts and the myoepithelial cells. In this case, P63 is positive in the vast majority of tumor cells, whereas P40 is negative. So that's very unusual. And then last but not least, don't forget about the cytology. These will be PTC-like nuclei, and then these are carrots. So I think I've reiterated that probably enough times now, but it's important to make the distinction between these two things. And then finally, remember, monophasic versus biphasic. So you're going to see the ductal structures here, which are very different from the myoepithelial cells in adenoid cystic carcinoma. All right, moving right along. Got another case, 55-year-old guy. He's got a parotid mass. All right, let's look at it. So it looks like a nodular lesion. It is infiltrative, right? It doesn't look like it's circumscribed. Looks like it's pushing into the surrounding parenchyma. Here's the histology. I actually had to steal this one from online because we didn't have really good examples of this entity in the files here. And unfortunately, I forgot to take pictures from the good entities I've had in the past, but I won't make that mistake. So anyways, I stole these from online, but this is what this looks like. This is a nodular tumor, so it has a nodular infiltration. It's not widely infiltrative usually, but it can be. In this case, it's very sort of nodular, sort of pushing borders. And then when we go to higher power, we can see that the cells here actually look biphasic. So we have these luminal cells that have a little bit more eosinophilic cytoplasm. So these are ductal cells here. And then we have these abluminal cells, which in this case have abundant clear cytoplasm. And that's sort of characteristic for this lesion is these myoepithelial cells that are really clear cytoplasm, and then these obvious ductal cells. Ah, crap. I didn't have my little thingy on this one. So you saw the diagnosis. All right. So I can't pip you guys on this. This is an epithelial myoepithelial carcinoma. So this is a rare tumor. It's around 1% of salivary gland tumors. That's why I didn't have a good example of it in my files. It represents about 5% of malignancies of salivary gland. Wide age range, slight female predominance, like a lot of these tumors. And interestingly, a majority of these things arise ex pleomorphic adenoma, and that's something that was only recently discovered a few years ago by the folks out in Pittsburgh. And by histology, these usually have a lobular growth pattern, as we showed in the last example. And it's classically a biphasic cell population, or by definition. So we have epithelial cells, the ductal cells, which have more like high NC ratio eosinophilic cytoplasm. And then we have myoepithelial cells, which are the cells surrounding, which have abundant clear cytoplasm. And you can see some basement membrane type hyaline material like you see in things like adenoid cystic carcinoma. So these tumors frequently recur and they sometimes metastasize. 5 to 20% of them metastasize, but up to half of them will recur depending on the series you look at. So, you know, they're not a tumor to mess with, but they may not kill you. And then the genetics of these things, if they arise from a pleomorphic adenoma, obviously they can have PLAG1 or HMGA2 rearrangements. Remember, those will be preserved in whatever tumor arises from the pleomorphic adenoma. But they also will show HRAS mutations in the lesions that don't have PLAG1 or HMGA2. So here's some more examples. We see, again, this sort of pushing border. Higher power, we see ductal cells here, more eosinophilic, lined by myoepithelial cells. So these will stain just like all ductal and myoepithelial cell tumors will, where you can see the biphasic population. And sometimes you can get this sort of cystic change and almost like this like papillary cystic change where you get these little papillary projections into the lumen of these cysts. But if we go to higher power on these papillae, we can see that the two cell population is still preserved actually, which is sort of interesting, where we have like myoepithelial cells here, a little more clear cytoplasm, and then ductal cells here. And same thing in these papillae, so ductal, myoepithelial. So just a different architecture. The more classic architecture is this one, where you see, you know, ducts and myoepithelial cells in sort of these sheets with myoepithelial cell overgrowth. And this is that article I referred to from the folks in Pittsburgh. And they found that the vast majority of these things probably do arise from pleomorphic adenomas. So all these represent cases of epithelial myoepithelial carcinoma, and if rearrangements, HMGA2 or PLAG1, about 60% of the epithelial myoepithelial carcinomas. And then there were other lesions where they just saw this sort of like hyalinized nodules that suggested a prior pleomorphic adenoma. And the other thing to notice here is that if they don't have HMGA2 or PLAG1, they probably have an HRAS mutation. So the lesions that didn't have these often showed HRAS, including some that likely arose from pleomorphic adenoma. All right, so that's epimyoepithelial carcinoma. All right, so let's move on to tumors with abundant cytoplasm. We got to really move. I'm running out of time. So salivary gland tumors with abundant cytoplasm, it's a pretty wide differential, including benign and malignant lesions. Again, these are just sort of like your standard de facto grades for these lesions. And you can bump some of these things up, like you can have actinic cell carcinomas that undergo high-grade transformation. The other thing to note is that anything that has myoepithelial cells can be both sort of basaloid in appearance versus oncocytoid in appearance, because myoepithelial cells can look so different. So that's why epimyopathy carcinoma and myoepithelial carcinoma are on this list as well. All right, so 45-year-old woman with a parotid mass. Let's look at this. So this lesion looks like it's infiltrating, but it's got that pushing infiltration that's more characteristic of a low-grade lesion, right? As opposed to the widely infiltrative thing that you saw in like the adenoid cystic carcinoma. And then we look at the histology and we can see that it's going again with this sort of pushing invasion. And it's sort of like got a nodular appearance on low power. And then higher power, let's look at these freaking cells. I mean, they're impressive. They're very abundant cytoplasm here, which is very zymogen granule rich. And then here's another area where here we have sheets of cells, right? Some of them cells here don't have abundant cytoplasm. They have more like minimal amounts of cytoplasm, which is somewhat clear. So these are like cells that are trying to become intercalated ducts actually, but the vast majority of these cells are different. And then we have sheets here, but we also have this sort of microcystic pattern, which you can see in this tumor. I have some lymphocytes infiltrating here, which is very common with this tumor. Again, some of the cells show like intercalated duct differentiation. Because it's not like these things are in continuity with each other, like ductal cells surrounded by myoepithelial or basal. We don't call this biphasic, though technically they do show somewhat different morphologies, don't they? But yeah, we call this a monophasic tumor. It's just they're differentiating into both these cells with abundant zymogen granules as well as this more intercalated duct type. So what is this?
Actinic cell carcinoma.
Nice, bro. Oh my God. You're coming for my job, aren't you? You're coming for my job. I don't want to recruit you anymore. I think you're going to replace me. Anyway, so yes, well done. So actinic cell carcinoma. So this is a low-grade carcinoma. Majority of these occur in the parotid, which makes sense because that's where you have most of these serous zymogen granule rich acinar cells. Wide age range, though this can occur in children and younger patients, and the mean actually is people in their 40s. So I'm approaching this age group, and there is a slight female predominance. So we just described the morphology, so I'll spare you going into all of this in detail. The one thing which is interesting to note is that this is one tumor that frequently has tumor-associated lymphoid proliferation, which I'll show you, just a bunch of lymphocytes, which can almost mimic a lymph node. And by IHC, these are positive for DOG1. Remember, that's a marker that marks normal acinar cells, as well as SOX10, which again marks normal acinar cells, but also this new marker NR4A3, which unfortunately we don't have here. And then they're negative for these other markers, which we use for a different lesion we'll talk about. And by molecular, there are these NR4A3 rearrangements, which again, were only recently described. Prognosis, relatively good. You can have recurrences in a third of cases around, but you can get lymph node mets in about 10 to 20%. It's pretty rare to die of this disease, but it can happen. So here's a low power image. This sort of has, again, that sort of pushing infiltration where it has this sort of mushroom cap here, similar to a follicular carcinoma in the thyroid gland. Another low power picture where you can see that it's sort of encapsulated. And in this case, it doesn't really even look that infiltrative. So this is one of those lesions where, you know, it can be completely encapsulated. It's still malignant. Again, completely circumscribed, maybe a little pushing, but it's not infiltrating into the surrounding parenchyma. But by definition, this is malignant. There's no such thing as a benign acinar cell proliferation in the parotid. And here's just an example of the nice microcystic proliferation we have here. And then here's a microcystic population where you actually don't really see much zymogen granules, but there are some scattered cells where you can see that they are truly zymogen granule rich. And this is 100% specific. So if you have zymogen granules in your tumor, cells like this that are clearly acinar cells, you just don't have to do any stains. That's it, you're done. So here's an example of a tumor with TALP. So this is a lymphoid proliferation. So this can sort of mimic a lymph node. It's just an unusual pattern. We see it with actinic cell carcinoma very frequently, and also mucoepidermoid carcinoma. Just gonna spend a minute talking about this paper, about this new stain, NR4A3. So it turns out the majority of actinic cell carcinomas will show a translocation of NR4E3, and this is associated with increased expression of NR4E3. So in this study, they had 64 actinic cell carcinomas, and almost all of them, just a single one of them, didn't stain for NR4E3. So the vast majority of these things were positive for NR4E3. And then if you compare it to all the other things on the differential diagnosis, like anything you could consider, including just benign acinar cells. Let's say you have a biopsy and you're like, is this malignant or is this just some weird acinar proliferation? Normal acinar cells won't express this either. So it's pretty damn specific. So I really hope we get this marker in the future. All right, 40-year-old male with slowly growing parotid mass. And look at this. Similarly, circumscribed lesion looks sort of encapsulated, but it is pushing here into the surrounding parenchyma. And then on higher power, we see cells that do have a bunch of cytoplasm, but in this case, the cytoplasm looks a little more eosinophilic, and they are in something that looks like sort of like a microcystic pattern, but they also have this unusual colloid-like material with these bubbly secretions here. Again, another power, we see it's sort of like colloid-like material. We have finely granular pink cytoplasm that really actually shows a bunch of vacuolizations too. And then another higher power just to appreciate the cell morphology with this beautiful pink bubbly cytoplasm, and then these little almost colloid-like secretions here. What is this? I know you guys know this one.
Can I try my chance?
What's that?
Can I try my chance?
Yeah, go for it.
Mucoepidermoid carcinoma.
Oh, bro, you're finally wrong. Oh, that's good. That's good. It's not, but that's a good guess because there are these secretions here which almost look like mucin.
I'm sorry.
No, you are killing it. I really appreciate it. And that is a good guess. The one thing is that these are all one cell type. Mucoepidermoid carcinoma, I'll show you, has 3 different cell types. But that's certainly on the differential for this. So that's not a bad thought at all. But I'm glad you're not taking my job tomorrow. Anybody else?
Secretory.
Yes,
Secretory.
nice.
Mhm.
Well done, Troy. Yes, this is secretory carcinoma. So this used to be called mammary analog secretory carcinoma because there's a tumor in the breast, which is morphologically identical and has the same translocation. But yes, this is secretory carcinoma. We just dropped the mammary part because the salivary gland is just important as breast. So low-grade carcinoma with a good prognosis, wide age range, but usually patients in their 40s. You can see these in young patients as well, adolescents too. And this one actually does have a slight male predominance, which is slightly unusual. Most commonly in the parotid, followed by minor salivary glands. And we just looked at the histology. Bland vesicular nuclei with these little pinpoint nucleoli, abundant pink to pale granular cytoplasm. And they have this vacuolated bubbly secretions. And they have a characteristic fusion of ETV6 and NTRK3. And this is seen in almost 100% of tumors. There are rare variants, but the vast majority of these things will be ETV6 and NTRK3. You can also see ETV6 with other translocation partners. Hey, thanks. And this is important because this leads to NTRK3 upregulation, and that's something that can be targeted with therapy. So it is actually important to distinguish this from something like actinic cell carcinoma, which is also on the differential. Prognosis, though, is similar to actinic cell carcinoma. So you get recurrences in around 1/3 of cases and lymph node mets in around 20%. So it is pretty rare to die of this disease, but every once in a while, especially if they undergo high-grade transformation, they can be bad actors. So again, this is why we really want to make the diagnosis because there are these new targeted therapies to track. So try to make the right diagnosis here to help your patient out. So low power, you can see it's sort of a pushing infiltration. And then higher power, again, we see these cells with the pink, finely granular cytoplasm, these lumens with these little colloid type secretions. Another picture here where we can really appreciate that the colloid here has this sort of like secretory bubbles. It almost looks like the scalloping you see in like Graves' disease when you get when the thyroid's really super overactive. And then let's say you don't have NR4A3, like most institutions in the world. You can still use some old standby IHC to differentiate this from actinic cell carcinoma. So actinic cell carcinoma is going to be positive for DOG1. It's like 95% of these actinic cell carcinomas in this study were positive for DOG1, and it'll be negative for mammoglobin and S100, whereas secretory carcinoma will be positive for mammoglobin and S100, negative for DOG1. So if you just do these 3 stains, you should be able to differentiate them, and you usually don't have to send it for molecular to make the diagnosis. But having said that, if the patient has really aggressive disease and they want to target it for therapy, they're obviously going to have to send for the molecular to confirm that there is actually an end-track rearrangement. And then remember, if you have ETV6 FISH, you can also do that. And you can see this rearrangement here with the break apart probe confirming that this is secretory carcinoma. All right, 30-year-old woman with a fluctuant parotid mass. Looks infiltrative, somewhat cystic, maybe a little necrosis here, it's hard to say. We see cysts that look like they have a bunch of mucin in them. Now we go to higher power and we see mucinous cells here. We see some cells that are sort of like pink, minimal amounts of pink cytoplasm. Go to another power here, and we can see mucinous cells, cells with a little bit of pink cytoplasm, some cells with more abundant eosinophilic cytoplasm. So I think you guys know this one. This is mucoepidermoid carcinoma. So this is the most common salivary gland carcinoma. I'm just throwing it randomly towards the end of the talk just to keep you on your toes. But this is the most common, 15% of salivary gland tumors. There's a really wide age range, and it's the most common salivary gland malignancy in the pediatric population as well. So you can see this one in kids. This is female predominant tumor. And the histology is like we just showed. There are 3 cell types: mucus cells, intermediate cells, and epidermoid cells. I'll show you those again in some other pictures. And then we tend to get these mucus pools, particularly in low-grade lesions, which tend to have more cystic differentiation. By molecular, they have mammal2 rearrangements in about 3/4 of the cases. And the most common rearrangement is CRTC1 with mammal2. You can also see this CRTC3 with mammal2, but mammal2 rearrangements will be most common. So we often, if we have a question of mucoep, we'll send for mammal2 FISH. There's a really wide prognosis, and it sort of depends on the grade of these lesions. So this is one lesion that has a variable grade, so we have to grade it ourselves. And depending on the grade, it can have really different rates of survival. So low grade, really good survival, 98% disease-specific survival, whereas for high grade, there's significantly worse prognosis. And these are different grading schemes. I'm not going to expect you to memorize this. I don't memorize this, but I pull this up literally for every single case of mucoepidermoid carcinoma I get. And I'll just go through all these different schema and come up with how they would grade the lesion. And usually they're relatively consistent, so we can feel confident calling it low, intermediate, or high grade. But sometimes there's some differences in the grading, and there's some nuance. The AFIP system famously downgrades tumors. So as a result, the intermediate cases, what's left in the intermediate category will be more aggressive, right? Because a lot of those other intermediate tumors are being downgraded to low grade. And then conversely, the Brandwein system by my pal Margie, that sort of upgrades tumors. So she's very aggressive with the way she grades tumors. So a lot of the cases we're calling intermediate there are probably going to be more like low grade, because everything that was more higher grade of the intermediate category tends to be called high grade for this category. So just little nuances to be aware of, but I do all of these on every single case. All right, and then these are the 3 cell types. You have these epidermoid cells. They're called epidermoid because they look like keratinocytes with this abundant eosinophilic cytoplasm. You also have these intermediate cells, which are these cells that are, have sort of moderate amounts, not abundant cytoplasm, but moderate amounts of this more cleared out cytoplasm. And then of course you have the classic mucus cells. These are the goblet cells here producing mucin. This is a case where it's more epidermoid cells and intermediate type cells. I don't see any goblet cells in this picture. So this is probably a little higher grade. All right, I'm going to try to rapidly get through as much as we can now. We have 5 minutes. So this is an aggressive lesion here. Look, a little necrosis. It's a bad boy. And on resection, we see an infiltrative tumor. On another power, we see that the cells are surrounding nerves here. They're highly infiltrative into the surrounding parenchyma, and the cells show abundant eosinophilic cytoplasm, have some of these weird like pink, almost decapitation type secretion look that looks sort of like apocrine type cells. And they're in a cribriform pattern. So it sort of looks like an apocrine carcinoma of the breast. And then we see really like just poning these nerves here. These nerves don't stand a chance. Again, very eosinophilic cells, finely granular cytoplasm, some prominent nucleoli, and you'll see abundant mitoses in these lesions as well. And this thing is positive for androgen receptor. So what is this?
Salivary duct carcinoma?
Yes, who is that?
Oh, this is Melanie.
Oh, Melanie, nice, good job. You haven't even been on our rotation yet. You're just a badass, okay.
Saving the best rotation for last.
Oh yeah, I like the way you talk. All right, you can come for my job too. So yes, this is salivary duct carcinoma. So this is a wide age range, but it's usually older patients. And this is one of those tumors, sort of like secretory carcinoma, that has a male predominance. In this case, it's more of a male predominance here. So unfortunately, we tend to get the more aggressive lesions, but in general, we get less lesions. So I guess it evens out in the end. Major salivary glands, 80% of them are in the parotid, and they may arise de novo or part of an pleomorphic adenoma. As I showed earlier, I think I showed an example of salivary duct carcinoma XPA. We talked about the histology. These are positive for androgen receptor. They'll be positive for GATA3. So it really will stain sort of like an apocrine carcinoma of the breast. And they're negative for P40 and P63, which can be helpful with the differential diagnosis, as I'll show you. By molecular, they show alterations in the PI3K pathway, so PTEN loss, HER2 amplification, and PIK3CA, which leads to all these mutations will lead to more activity of this pathway. And then if they arise XPA, you can obviously see the alterations that you would see with the pleomorphic adenoma. Poor prognosis, so majority of these will have METs, and the 5-year survival is only 45%. So this is a really bad tumor. And again, very eosinophilic, finely granular cytoplasm. You can see overt pleomorphism, prominent nucleoli, apoptotic bodies galore. You'll commonly see comedo-type necrosis, as you see in the breast. But yeah, the differential, you could think about a high-grade mucoepidermoid carcinoma because those cells can have a decent amount of eosinophilic cytoplasm. In this case, I think I do appreciate some intermediate cells here and then some epidermoid cells here, whereas this looks like a single cell type, but they can look somewhat similar. So really to differentiate those two, just get the androgen receptor. So 100% of salivary duct carcinomas basically will be androgen receptor positive, depending on the series you read. And then things like mucoepidermoid carcinoma, not positive. And very rarely squamous cell carcinoma will be positive for androgen receptor. Conversely, salivary duct carcinoma will usually be negative for P63 and P40. So in this study, 87% of the salivary duct carcinomas were dead negative for P63. And the ones that did stain only showed a little bit of staining. And if you compare that to mucoepidermoid carcinoma, the vast majority of mucoeps will be positive for P63 or P40, particularly the high-grade lesions, because those are the ones that have more epidermoid type cells. And those are the cells that are positive for P63 and P40. So if you just get an androgen receptor and a P40 or P63, you can separate salivary duct carcinoma from either high-grade mucoep and squamous cell carcinoma. All right, well, you know, we have just 2 more lesions, I think, but I'm actually out of time. So what I'll do is I'll just keep going and just finish it for anybody who's like on a, you know, an easy rotation or off service or whatever. But everybody else can feel free to leave and I won't be insulted. And I apologize for going over. I just really can't help myself. But probably only about 15 minutes left max. So if you stick it out, you don't have much left. All right, so here's a 50-year-old male with a parotid mass. Now let's look at this lesion. Now this shows some infiltration into the surrounding parotid, right? But it has these interesting nodules that appear to be surrounding this sort of hyalinized material here. So it's sort of an interesting pattern on low power. Higher power, we see, again, these sort of like nodules that are surrounding this hyaline type material. And then here we have the neoplastic cells. And on higher power, we can see that these cells are really just a single cell type. So it's just these cells that look sort of epithelioid, maybe a little spindled in some areas. So I'd ask you what this is. I don't really want to waste time. This is myoepithelial carcinoma. So this is relatively rare. It's 2% of salivary gland malignancies, less than 1% of salivary gland tumors overall. Can occur in any age range from adolescents to adults, and equal gender distribution. Usually occurs in the parotid, like most of these tumors. And these can arise de novo or ex pleomorphic adenoma, similar to salivary duct carcinoma and epithelial myoepithelial carcinoma. And the histology is what we just saw. It's a pure myoepithelial cell tumor population, but unlike myoepithelioma, which we're not talking about today, this one shows invasion. And they classically have this sort of expansile and lobulated nodular growth, and they will frequently have those little central areas of hyalinization, and they have this, what's called a zonal cellular distribution around those hyalinized foci. So this is more of an intermediate grade tumor. They can be high grade as well, but generally they are associated with an intermediate prognosis. So they frequently recur, and they occasionally will have lymph node and distant mets. All right, so just some more examples so you can get a sense for this sort of zonal distribution that we saw. So look, it's infiltrating, but it's more pushing. It's not completely highly infiltrative, but look at this zonal distribution of cells here with the cells surrounding this hyalinized type stroma. Again, similar thing, we have this hyalinized stuff here and then a zonal distribution of cells around them. And with this more pushing kind of infiltration. Here's another example with the real nodular growth pattern on low power, but again, this weird zonal distribution. And then when we go to higher power, remember they're myoepithelial cells, so they can really look like anything, but in this case, there's more epithelioid. And then sometimes you can see a little bit of a chondroid stroma in the background too. All right, this is the last tumor we'll discuss. So this is a 50-year-old woman with a palate mass. All right, so we resect this sucker. Now this is a real, this is one of the more exotic tumors I'm gonna show today. So canalicular adenoma was the first. This one's probably even more exotic. So this is a palate mass we've resected. Looks relatively well circumscribed, sort of a nodule that these frequently will just push into the oral cavity. It'll be sort of like this nodular protrusion. And then we go to higher power here and we can see this really dense hyalinized stroma, very dense stuff here. And then these cords and sheets of tumor cells, some of which look relatively cleared out. Go to another power here and we can see that this is actually a relatively cellular spindled stroma here. And then again, the tumor cells in some areas look somewhat clear. In some areas, a little bit more eosinophilic cytoplasm, but we don't really get the sense that this is biphasic per se. It's probably the same tumor cell type. It's just they have different morphologies depending on the field we're looking at here. Again, another field where we just have sheets of these tumor cells with somewhat cleared out cytoplasm, and then this really dense sclerotic stroma. So if you guys know this, my God, I'll make sure no one ever fires you ever if you know this. I'll call your future bosses, tell them they're not allowed to fire you. Anybody know this?
Yes.
Annie does? All right, what is it?
Well, old term, hyalinizing clear cell, new term, just clear cell.
Okay, awesome, well done. All right, you're not gonna get fired.
Yay!
So well done. And she got it with the terminology right. So this is hyalinizing clear cell carcinoma. So it used to be called hyalinizing clear cell carcinoma. In the new WHO, they just called it clear cell carcinoma. I don't know why they keep changing these names, but whatever. Now it's called clear cell carcinoma. It's relatively rare, quite rare. I've only seen a couple of these in my life, though it's a short life, I'll admit. Less than 1% of salivary gland tumors. There's a really wide age range, slight female predominance, and these things will occur in the minor salivary glands most of the time, vast majority. So this is up there with polymorphous adenocarcinoma and canalicular adenoma. Remember, those are the three tumors that almost always occur in minor salivary glands. And they'll be, they're infiltrative and they're composed of these little trabeculae and cords. The cords are rather characteristic of tumor cells. And the tumor cells will just have this sort of clear to eosinophilic cytoplasm like we saw. And classically, the hyalinized stroma, which is why we had that old name, hyalinizing clear cell carcinoma. The stroma can also be relatively cellular. So classically, there are these two stroma types that are described. Hyalinizing is more common, but you can also get like a cellular spindle cell, fibroblast rich stroma. And they can show mucin, so it can be on the differential with a clear cell variant of mucoepidermoid carcinoma. So these are positive for P40 and P63. So they basically stain like squamous cell carcinoma. But the one thing that you need to be aware of is that they can also be positive for P16 and frequently are positive in varying degrees for P16. And that can be a problem because these things can occur in the base of tongue. So it's one of the more common areas for these things to occur. And if you're not thinking, you could just order P40, P63, say, okay, I got squamous cell carcinoma, P16, say, okay, HPV mediated squamous cell carcinoma, next case. And these things will act very differently and they're not responsive to radiotherapy. So that can get you into trouble. So just be aware they can stain like an HPV mediated squamous cell carcinoma, but they really don't look like it. So if you're not on autopilot, you should be able to differentiate the two and just keep this in the back of your mind. By genetics, they show an interesting EWSR1 gene rearrangement with ATF1. And prognosis, it's a low-grade tumor. So they do have rare recurrences, occasionally lymph node mets. It's very rare for people to die of this disease, but it can be associated with recurrences and lymph node mets. All right, so just some pictures of this. You can see the dense hyalinization here at the center. This almost has that kind of zonal distribution, doesn't it? Yeah, this is actually a clear cell carcinoma. And then higher power, we see that there are clear cells and more eosinophilic cells. In this case, in like a somewhat cellular stroma, you can see some fibroblasts here in the stroma, as opposed to the densely hyalinized stroma that we saw in the other example. This is that more densely hyalinized stroma, various amounts of cytoplasm, often with clear cells. And here's one that's really clear cell rich and also has that classic cellular stroma as opposed to the hyalinizing stroma. So if you see this, you might even consider something like a metastatic clear cell carcinoma from the kidney. But notice it doesn't really have the same level of vascular pattern, but you still might want to exclude it. So get your PAX8, get your P40. Just another high power image of these beautiful cells with the clear cytoplasm. All right, so I was going to do a rapid fire quiz. I just like this slide too, but because it's we're already over time, I'm not going to go through this little quiz of these random lesions, but I'm going to share this PowerPoint with you guys so you can look at these images later. So I guess that's it. And I guess, we have plenty of slides here and we can do slides some other time, but I really want to get through as much of the didactic as possible because there's just so many freaking lesions to talk about. So that's it.